11:30. I'd like all the members, if they can, to come and sit up here, if you would, as much as there's room for.
New friend. You're a new front row friend. I have to sit in the front because
And they understand.
makes me pay attention.
Yeah, I'll show you.
When you're Auburn, I feel like you're lonely in the back here. There's no one to sit around you. Hopefully more people will show up. You don't have any friends.
I'm just sitting here with all my friends.
How are you today? Good. I mean, it's Monday, and I had a good weekend. It's a little fallish outside.
Yeah, we were having an early autumn,
Yeah.
which means stand by for the rain.
Yeah.
Which I'm okay with at this point. I'm tired of being warm, so.
Absolutely. Well,
I got 11:30. Are we ready to get going? Is everybody that needs? That's what I said, wasn't it?
I started out with this folder, and then I told them to put.
Whatever time it is, it's time to get started. Okay. Is anybody down there that needs to be up here? No. Okay. Miss Asia, would you call roll?
Senator Albritton.
Present.
Senator Orr. Senator Coleman Madison. Representative Reynolds. Representative Garrett. Representative Warren. Mr. William Ashmore. Mrs. Dorian Carlton.
Present.
Miss Jillian Cohen.
Present. Is that Jewel
Cohen, sorry, yes.
Present.
Mr. Patrick Dean.
Present.
Dr. Eric Mackey.
Present.
Miss Jo Moore. Miss Lori Morgan.
We got everybody? All right. First off, we do not have minutes to approve today. All right. That's my failing. But we will have those ready to go, ready for approval in our next meeting. Okay. So we'll forego that or delay that approval or anything until next time. However, in order to make sure that I don't screw that up again, who's going to take minutes today? Who's willing to volunteer to take minutes? I see several people standing. I know everyone's busy. Asia, you got it? Okay. She was the only one standing. With that, I believe we have a presentation that's going to be brought forward by Blue Cross Blue Shield. I'd like to go ahead and move forward with that if that's okay.
All right, good afternoon.
Good afternoon. Thanks for coming.
Yes, so I will introduce myself. I am on the commission. I'm the appointed industry representative. And I'm Jill Cullen. I'm Chief Actuary at Blue Cross Blue Shield of Alabama. And I have brought some information today at the request of SEIB and PEEHIP that puts some of their information side by side and compares and contrasts them. All right, so I'll start by level setting us on what is in the presentation and what is not. So we've got kind of some bullet points here, starting with the time frames. You'll notice that there are 6 time periods in almost all of the slides. A few of the slides are more recent snapshots. Those 6 time periods are primarily service dates within a calendar year, but they're off a little bit. Blue Cross uses an external data vendor to aggregate our massive amounts of data, and that data vendor is in the middle of an annual rebuild. So we're a little bit delayed. So the data is incurred or service dates as listed on the left of that chart, all with full run out through January or through March of 2024. Just a level set on how the slides are set up. When there's more than 1 year on a slide, we always have the oldest year on the left, the most recent years on the right. So it just kind of goes forward consistently page by page. Next bullet point under the chart, we've got some comparisons to a Blue Cross book of business. The request last time was to look at things in comparison to more of a private insurance book of business. So we've taken all of our business that's headquartered in Alabama and taken out SEIB, PEEHIP, and local government. So those are our government business that's really large size, and we've taken it out so you've got more of a commercial comparison. Next, this is medical claims only. Blue Cross does not administer the pharmacy benefit for either customer, and so we have taken the pharmacy claims out of the book of business so we can have a consistent comparison. There are medical specialty drugs in this data set. Those are drugs administered by a provider in a professional or facility setting, typically pretty expensive drugs. And then lastly, we do not have Medicare eligible retirees in this, so it's more of an active look at under 65s. Any questions on that level set? Okay. All right, so we'll start with a demographic snapshot. This is as of January 2024, so it's a pretty recent snapshot. You can see the contract and member size. Contract is what we would call the policyholder or the employee. Member is including employees and dependents. So you'll see, I'm just going to focus on members, just the larger number there. We've almost got 224,000 or just over 223,000 in PEEHIP in January, over 61,000 on SEIB, and then over 1.1 million in the Alabama book of business. So three very, very credible blocks of business to be comparing today. Some other interesting demographics are percent male and percent female. You'll see that PEEHIP has the highest percent female on the list today of the groups we're comparing, and the Blue Cross book of business would be the lowest. And then another interesting comparison that is a descriptor of some of the cost differences is our single-only contracts versus spouse and dependent contracts. So the big numbers I would point out on this table are that our Blue Cross book of business has a 56% single-only mixture, whereas state and PEEHIP have more dependents. And the primary thing I would point out here is that PEEHIP has 21% spouse dependents and then 37% child dependents. That makes the average age of PEEHIP a good bit lower, which actually all else equal makes the cost lower when you're looking at all these together. I would also say just generally, dependent mix varies by industry, but it also varies by contribution amounts for employees. And so we've got information from state and PEEHIP today that show what their contribution amounts they expect for single and family contracts, and that does drive some of the high family mix because it's relatively generous contribution expectations that the group is covering for the employees. All right. So I mentioned average age a minute ago. I want to level set on what all the charts look like as we start. So you'll see, as I mentioned, older years on the left, newer years on the right. There are 3 bars for each year, and they're all following in the same order every time. So we start with PEEHIP, then SEIB, and then Blue Cross Book of Business. So PEEHIP in green, SEIB in blue, and Blue Cross Book of Business in yellow. We showed all of these years because I wanted to emphasize how consistent they are. So your average age across all this time period, if I just focus on the far right, PEEHIP is nearing 37 as the average age, state 39, and Blue Cross Book of Business at 34. That is a big driver of the cost differences between age and gender. That is a very, very primary, there's primary correlation there between claims cost and age and gender. And if nothing else were different between the populations, age and gender alone makes state 8% more expensive than PEEHIP. Even if they had all the same health conditions and everything else, those younger child dependents on PEEHIP make the average cost on PEEHIP a good bit lower, about 8%. And I'll also say you're going to see this pattern throughout the slides, where state's at the highest in the middle bar, followed by PEEHIP in the first bar, and then followed by Blue Cross Book in the far right bar. There's some differences in how different they are, but they're pretty consistent as far as the general shape of all these graphs. Next, we'll look at high-cost claimants. We call that HCC. You could choose all kinds of thresholds to define an HCC, but for this purpose, we chose 100,000. So it's at the bottom of the slide. Anyone that had 100,000 or more claims in each time period gets included in this data set. This slide is percent of members, and those are very small percents. On the far right, just to call them out, state is the highest at 0.52%. That was 340 members out of all 60,000 that we talked about earlier, over 60,000, only 340 members were more than $100,000 in claims in 2023. Followed by PEEHIP at 0.43%. That was about 1,000 PEEHIP members in 2023. And then the Blue Cross Book of Business is 0.42%, and that's about 5,500 members. Just to give you a general idea of the kinds of conditions that people have that fall into this category, there's some tie-ins with chronic conditions, but there's also what we would call more random variation, such as accidents. We also have a lot of members that fall into this category with some expensive cancers, chronic kidney disease, sepsis infections in the facility setting, premature births, and cardiac events are the ones that boil to the top that hit this 100,000 threshold. Key point I want to make here, even though you see the shape that I mentioned earlier, let's call this about 0.5% of members. Out of 100 people, only half a person hits this threshold. It's a very, very small set of people. But if we look at the next slide, this is allowed amount per HCC. So how much we, as Blue Cross and the groups and the members as part of their cost sharing spend in settings such as the high cost situation. So you'll see off to the left, you've got the scale here. We didn't try to put the numbers on every single dot on the line. I'll also tell you the line labeling here. In green, PEEHIP is the dash, 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 solid dashes. In blue, SEIB is dash, dot, dash, dot. And then lastly, Blue Cross Book of Business is the solid yellow. And you'll see that really, if you look off to the scale on the left, we're right around 200,000, 190 to 220,000 in this time period. You see an upward trend, but there's some variation there. Some years one's higher than the other. But the main point here is for those 0.5% of people we were talking about, we are spending over 200,000 per person for those 0.5% of people. And you add up all their claims for the year and it makes up 21% of the claims for each population. So 0.5% of PEEHIP members, that's about 1,000, make up 21% of the claims for 2023. And that really was true for several years before that. Same is true for the a few hundred SEIB members. They make up 21% of the claims in 2023. So that very small amount of people make up a whole lot of the claims. Like I said, some of these things are tied to chronic conditions. Some are a little bit more random variation, but there is a lot of correlation with the chronic conditions as well. Okay, so then we're going to look at some chronic conditions. We selected some that are pretty common. You hear about, the first one we selected was asthma. And I must say, this is the one place where PEEHIP is higher than SEIB, primary related to females and children are more susceptible to asthma diagnosis. So on average, with PEEHIP having a higher female population and a higher child population, this is the chronic condition with a higher prevalence for SEIB. And you'll see there's some ups and downs by year, but it's roughly 5% for SEIB and PEEHIP both of the population have asthma, and more like 4% for the book of business. Next chronic condition, congestive heart failure. This is a much smaller prevalence. It's kind of more like the high-cost claimant prevalence with less than 0.5%. Here again, you see the shape of SEIBs at the top in the middle, followed by PEEHIP on the left, and then followed by Blue Cross Book of Business on the right. Next, chronic kidney disease. I mentioned this is one of the ones that does bubble up to high-cost claimant category sometimes. You've got when someone is on dialysis, you've got primary responsibility for them before they move on to Medicare, and while they are on the group plan, they are very, very expensive once they're on dialysis. Here you've got a little bit of a range, and you kind of see some upward trend here, but we're at 1% for SEIB, 0.84% for PEEHIP, and 0.6% for Blue Cross Book of Business. Next is coronary artery disease, or CAD. Very similar pattern here. You see again some upward trend on all three categories. A little bit higher prevalence than the CKD, 3.7% for SEIB, 3% for PEEHIP, and 2.5% for Book of Business. We noticed that a lot of these chronic conditions start with a C, so here's another C. Chronic obstructive pulmonary disease. This one's got a little bit of a downward trend across all the populations. Again, not super high prevalence, but the similar shape again, state at 1%. Here's a place where Book of Business is a little bit higher than PEEHIP at 8.5 and PEEHIP at 0.74. So then next, cancer, not a chronic condition, but definitely a big cost driver. And some cancers are tied to chronic conditions. I should probably also add the prevalence in each of these graphs is not unique. People can overlap and have more than one condition. So here you've got some ups and downs by year. A little bit of that is probably some random variation or maybe some timing of cancer screenings during some of the shutdowns. But we do have, again, a similar pattern with state being highest at 2.4, followed by PEEHIP at 1.9, and Book of Business at 1.5. And then the last chronic condition my team and I selected was diabetes. This one's very concerning and definitely a big cost driver. We know diabetes is a very concerning condition in this state and in the Southeast, and we're doing a lot to work on it. But here again, you'll see, similar to prior, that state is the highest at 17%, PEEHIP at 13%, Book of Business at 10%. All of those have an upward trend. Not that this is the purpose of this meeting, but I will mention Blue Cross is working a lot to do some things about diabetes. We're working with our group customers for some different employee-facing interventions and programs. We're working with our providers for some value-based programs to incent them to get some quality ratings and treatment patterns that should help bring this condition to light sooner so people can get treated sooner. And then there's also some statewide and community efforts as well. Any questions on those chronic conditions before I move on? The next one's a little complex. Okay. This was one that SEIB and PEEHIP requested that I add, just because it's got some interesting information. Let me talk through what all is on here. So let's start with the bars. The bars, again, same colors and order as all the prior slides. You will notice there's only 5 years on here instead of 6, just because of the data source availability. So I will also say for the bars, the legend for the bars or the scale is on the left. So the bars represent admits per 1,000. Per 1,000 is a per capita measure for hospital admits. There's so few admits that if you do a prevalence or a percent of members, it's going to be a really small decimal point percent. So we instead, as an industry, use a per 1,000 measure. What that means is for every 1,000 members, this is how many admits you would have in a hospital inpatient setting. If you look at the scale off to the left, those bars are all in the roughly 45 to 50 admits per 1,000 range. That means for every 1,000 members in a calendar year, there will be 40 to 50 hospital admits. So not many people are going to the hospital, but when they do go, they are expensive, and it's definitely a life event for them and their family. So that's kind of, you'll see similar shape as before. Blue on top is SEIB, in the middle, PEEHIP, and the book of business on left and right vary by year as far as which one's higher. Next thing on this slide is some dotted and dashed lines. Same color coding as before. Dr. Mackey? Yes. Sure.
Turn your mic on, Dr. Mack.
So where we see that kind of peak in 20 and 21, would that be COVID related, we think?
Yes.
Okay.
Yes. So those lines are average length of stay. That's what ALOS stands for. And it's just the length of a hospital stay once somebody is admitted. So during the pandemic, there was a time where things were shut down. I believe it was during the Delta wave, if I remember, in the fall of 2021 when things were shut down. Hospitals couldn't take anybody else, and those COVID stays were longer, and the more voluntary services were delayed. So the shorter stays were delayed, the COVID stays were longer.
That's fine. That's kind of what I thought. It was
Yes.
something related to that, so not likely to continue.
No. I think the main point here is you see in 19 where those dotted and dashed lines were, and then you see where they are in 2023. We're kind of back to normal is the main point here. And normal, so this scale is on the right, normal average length of stay is about 4.5 to 5, if you see where those lines are now. SEIB is the dash dot in blue, and it is higher. It's closer to a 5-day average. PEEHIP is the green dash, and book of business is the yellow solid line, and those are closer to 4.5. So I would say that fits, like I said, our book of business average and some of the other lines of business that my team monitors more closely. And we really are back to normal on the bars and the dashes and dotted lines here. That you've got about 45 to 50 admits per 1,000 members in a calendar year, and the length of stay for a hospital is about 4.5 to 5. I noticed on the benefit cost-sharing comparisons that state and PEEHIP both have a per-day copay after a hospital admit deductible. And that per-day copay, I think, is $25 to $30 maybe. So most people on average are paying whatever that hospital deductible is and then paying for 4 to 5 days at $25 to $30. That hospital cost sharing is a very tiny sliver of the total hospital cost. The plans are picking up the vast majority of the cost in that situation. Any other questions on that one? Okay. Moving on to population risk score. A risk score is a measure of relative health risk of each population based on age, gender, and diagnosis codes on medical claims. So these are the medical relative risk factors for these three populations. And once again, you see very similar shape. SEIB has the highest medical risk factor in 2023 at 1.12, followed by PEEHIP at just under 1.0, so 0.98, followed by book of business at 0.84. These are relative, so you just kind of look at how they differ between each other to see what we think the cost would be. And this is pretty representative of what the costs are for these populations. One last slide of data. This is the medical benefit richness. It doesn't say medical on the slide, but this is medical only, just like everything else in here. PEEHIP in green on the left. The member pays about 9% of the medical cost, and PEEHIP as an employer plan covers 91%. I'm going to say in the Affordable Care Act nomenclature, that would be considered a platinum plan. Platinum plan is roughly 90% covered by the employer or by the plan. SEIB, this is just current benefits. There have been changes over time. SEIB is very similar. The member is paying about 10% in cost sharing, and the plan is picking up 90%. I will say this is just on the benefit cost sharing. This is not on employee contribution to the premium. And lastly, the Blue Cross Book of Business is more like 86% plan covered, 14% member covered. That's kind of more in between a platinum and a gold plan, but pretty representative of what you would expect for more commercial business. It's a little bit less rich than government business cost sharing would be. So to wrap it up, I felt like a little bit of a broken record, but the shape of the chronic conditions and the shape of the average age and risk scores all kind of reflect what we see in the claims cost, that state is more expensive, followed by PEEHIP and then Blue Cross Book of Business. The medical benefits that we just saw on the last slide as far as benefit richness are relatively consistent between the two groups and a little bit richer than the Book of Business. And I will add on this Book of Business, we really were looking just at group business to try to get to what it would mean as far as employer coverage and benefit richness. And then the last bullet point is just when you take it all and put it together and consider how the demographics and chronic conditions and disease states differ, both state and PEEHIP look about like what you would expect, and they also look better managed than our Blue Cross Book of Business. We spend a lot of time with both state and PEEHIP and their teams talking about how to manage the care, how to make sure their members are getting appropriate care, and that is reflected in a well-managed claims cost. So that wraps up my comments. Any other questions or discussion?
If I might kick off, and then we'll give a few minutes for everybody to discuss or bring up points on this. But one thing that sticks out to me between the PEEHIP and SEIB, the difference is the amount of risk. One's more male, the other's more female. One is older, one is younger. Hence, you wind up with the state having a greater risk than the PEEHIP, which leads me to believe insurance is all about spreading the risk. Wouldn't it be a consideration of taking those two and combining so that we could lower the risk over everything, because the PEEHIP has a greater number of people and such? Would that not be a consideration?
I think that would be a combining of the risk pools. The average risk would still be the average risk, separate or together. Part of the difficulty I see in combining is that they lose the flexibility to manage their plans and to try new and innovative benefits and interventions that we sometimes will try with one group over the other, and if it works, we can put it in the other. If it doesn't work, we can take it out. So you lose a little bit of that flexibility there.
All right, thank you. Any other questions? Chairman Reynolds?
I do, Mr. Chairman. Just so, it's pretty much what you're talking about. I just want to understand the demographics of the workforce that we're comparing here. And you may have said early on, I'm sorry I was a little bit late, but the Blue Cross Book of Business, does that include local and county governments, or is that just private?
We took all the government business out, so it's going to be your private employer group business. It does also have the individual marketplace business in there as well. It's all on the same provider networks, and so we put it all in there together because it's all getting the same discounts and interventions taking place. But all.
So would it be fair to say that since we have some consistency in the demographics of the worker and the same type departments, if we did add those local Blue Cross Blue Shield customers in, it would certainly change this graph dramatically?
It would change this graph. I don't want to speculate on how it would change it because I haven't looked at local government all by itself. Because it, again, is different from the two groups we have before us today.
Okay, thank you.
Mm-hmm.
Any other questions? Did anybody get anything useful out of this?
I hope so.
Well, I did. Okay, I did. It gave me some clarifications and some matters that's important there. So.
Good.
No other questions on that? None?
Okay.
All right, thank you.
All right.
Appreciate that. We had meetings between PEEHIP and SEIB since the last meeting. Is that correct? Anybody want to give comments about what those meetings related to, or how we may have progressed, or what direction you think we may be needed to be headed in?
Sure. We did meet just to generally compare our plans, and as well as we worked with Blue Cross to have an understanding of how our plans compared to one another, because we'd never really done that before. So that was very helpful to us, but that was the extent of our meetings, unless, William, you have something to add?
You know, I think the main thing that we wanted to come out of this meeting is the difference in the demographics of these two programs. And Senator, to your point, if you take these populations and you combine them, it doesn't change the risk, and it doesn't change the overall cost. If one program has 3 high-risk members and the other program has 1 healthy member, when you combine the two programs, you're still going to have 3 high-risk members and 1 healthy member. Their claims are going to flow through the system, through Blue Cross's system, through the same medical management. They handle the medical management on the medical side. You're going to get the same pricing from the hospitals, same pricing from the providers. All that's going to stay the same. So I think Blue Cross did a good job of doing a comparison and showing that there is a difference in the demographics, which ultimately requires a difference in the funding level. And I think that's kind of where all this kind of got kicked off over the last year and a half, is that there's a huge difference in the funding level at the state level for these two programs. And the message that Blue Cross has conveyed today is that there's a big difference, though, in the risk of these two populations. I think we heard that, you know, both the state and PEEHIP program, you know, and I'm obviously biased here, but they're very well managed. I mean, we can compare to any of the other 50 states, and you're going to find that both plans are very rich benefit packages, but we also do it for one of the lowest costs in the country. Both plans have gone the last 14, 15 years, and we basically have kept our funding level. That's almost impossible to do in healthcare. So, you know, that was the message that, you know, we want to convey, and we always want to get better. Don't get me wrong. You know, we want to get better, and every day we can find some way to do that, and I think that's where this committee needs to go, is just, okay, how do we take everything we know today and continue to get better? But it's been good that, you know, that we've been able to sit down with PEEHIP and with Blue Cross and compare notes. I mean, we've always worked pretty close together, but here in the last few weeks, we certainly have worked very close together.
Is there any discussion or any consensus on where there might be some kind of overlap or shared services that might be able to lower costs?
In another way of looking at this too is, if you did, let's say, combine the two programs,
Now, I'm not talking about combining it. I'm just trying to find out if there's some.
yeah, well, and that's where I'm,
Okay,
just,
all right.
I'm just kind of thinking through, you know, and if you did say, okay, you combine the two programs, again, the claims costs are going to be what they are, because the risk of the population is not going to change. And the network pricing that we have for those individuals through the hospitals and physicians is basically the Blue Cross's network. So that's not going to be any difference. So you would say, all right, but if you combine the two boards, and I'm not saying that's where we're going, I think, you know, let's say SEIB was the program to be eliminated, you eliminated every bit of our administrative expense. You know, after you back out depreciation and things of that nature that we have to record on our financials, it's about $5.5 million. When you combine the two boards, you're talking about $2 billion in total claims. So, you know, as a fraction, it's just a small fraction of the overall. But that'd be $5 million. You could say, well, you save. But if you look at the way that the programs have been set up through the years, what has happened is we have a very healthy competition that takes place with us. I mean, the PEEHIP staff is very innovative. And believe me, there's been times through the years, I watch what they're doing, and it's not going to be long when I see it's working, I'm going to incorporate it into our program. Likewise, the reverse. If I come up with something, it doesn't take long, and I see PEEHIP will pick it up. There's a healthy competition that takes place between these programs, and I can tell you, just looking at some of the programs, and we've laid out some of those programs in those presentations before, we're talking tens of millions of dollars, and that's what's helped us keep our cost as one of the nation's lowest cost programs in the country. So, yes, you could eliminate one of the agencies. You know, if it was ours, you know, you're talking $5.5 million, but you're not going to be able to replace. You can't, even if you try to do that, you still have to have employees. You still got to be able to do enrollments, accounting, legal. So that really, even there, you're not going to eliminate all of that cost. I'm just simply saying, though, if you were to eliminate all of it, that's what
No, but if we have legal, I mean, insurance, this sounds too flippant, but insurance is insurance. So if we have two legal departments in SEIB and PEEHIP, is there some way we could use those services or combine or overlap on that, especially if they're contract? The same is true with other services, whether it be HR or some other means. Has that been looked at?
Well, I will tell you, on my staff, I got one attorney handling all the contracts. And it is a beyond full-time job for him to do what he's doing. Every time I've ever asked him, do you want some extra help? He says, no, I'll do it. So, and don't get me wrong, yes, we could always find, but I think that's where, you know, if, you know, PEEHIP, you know, continuing a tighter relationship, we could find those areas and opportunities working together. I don't know that, I don't see it as something that requires legislation or anything of that nature. But there's always opportunities, and that's where Joe and I could be working together on things to figure out where are those opportunities.
And to answer for PEEHIP, our staff, not only do we staff PEEHIP, but we also then share resources with ERS and TRS. So we have 4 attorneys, one of whom does governmental relations, and they serve not only PEEHIP, but they serve TRS and ERS and all of their needs. So I don't see where we could combine on that, and we do most of our legal work in-house.
Okay. Any other questions along that line?
Mr. Chairman?
Yes, sir.
I will, compliments to the young lady who did the presentation. So one thing I learned from this, and I think I kind of knew this, but her charts brought it out, is the difference in age category and thus in medical. As we get older, we all have more medical needs. And as I was sitting here, that actually surprised me, and then I thought about it. I thought, oh, that doesn't surprise me, because I take just my agency. It's the only one I know in depth. So mostly we hire people mid-career. And in fact, we almost rarely do we like hire somebody straight out of college, whereas on PEEHIP, they're hiring a lot of people who are 22 years old and primarily more healthy. I know many of them have chronic conditions, but more healthy than folks who are older. Then they would transfer. Those people start applying for jobs with us when they're 35 or 40, and they've developed more issues. So I wonder, I assume that may be true with other agencies as well, that people start state jobs later in life. And anyway, it explains something to me, because I have for a long time wondered why state employees had more chronic health problems. William, I know something you have to look into, than our public education employees, but I think her charts kind of bared out how that is the case.
Are you speaking of, I noticed on the charts on the congestive heart failure, and I'm just picking these two.
Yes.
Yeah, and most all of them, the state is much higher on those chronics than the PEEHIP.
But yes,
I thought
sir.
that was just because it was just old men.
Well, well, I think it is because it's old men, because young men teach in the schools. I mean, I think that if you take those very charts and then you overlay them with the age chart that she gave us, they kind of follow the same trend. And I had not, again, I appreciate Blue Cross doing that, because I had not thought about that before. Why is it that state employees, when you look at the charts, they look generally more unhealthy or less healthy than our public education employees? But when you weigh into that, how many of our, how many of our folks working in the schools are 20 to 26 years old, then it makes more sense. And so I don't have a question there, but it clarified to me something about why one group costs more than the other group. I don't know if they're a cost saving. And you're talking about in the administration, but even when you put the two groups together, you're still going to have the same mix of people out there somehow. So anyway, just an observation that it appears that the older we get, the less healthy we are.
Speak for yourself. I would, and I appreciate what we've given here, I do. But the frustration that comes in, and how do we explain this to our employees when we're looking at, we're going to have to increase their cost, and we're going to have to find a way to increase cost on taxpayer burden because costs are going up. Is there someone here can explain, especially when we're looking at hundreds of millions of dollars of increased cost? Where's that coming from then? If the claims are the same, and we're going to pay the claims as they come out, and the risk is not going to be much affected, why is the cost going up?
Drugs. More than drugs.
Are you volunteering for that too?
I don't know how to fix it. But I do, there's definitely a lot of discussion going on about the pharmacy space right now in the state and nationwide. I will also say...
You mean about all the ads about, what is it, D, the Plan D, is that what it is?
Well, that's its own cost driver because those benefits changed, right?
Uh-huh.
But I will just generally say the cost trend we see on these two groups, just on the medical piece, because that's all I can see, is definitely lower than what we see on our group business more generally. So as I mentioned earlier, with the well-managed populations, we do have a lower trend in our government business than we have in our commercial business. Most employer groups probably see, on average, 6 to 7% premium increase on the underwritten side that they have to decide each year how to pass along to their employees or how to cover it with their own expenses. So I just want to say we're unique in this situation that we've got to figure out how to put it on the taxpayer, but it is not unique in the situation that is more global.
You mentioned premiums. Premiums are going up?
Premiums are going up.
Is that just inflation?
It is inflation, but it's also, the other side of it is utilization. More services being used over time by the average member. Some of those things...
But from your charts, that seems to be coming back to normalcy.
That the inpatient is coming back to normalcy. Physician benefits and drug benefits are increasing every year. So there's a lot of trend drivers that we didn't even get into today, but I just want
More particular, is that because of we're using more drugs, or because the drugs cost more?
both.
Both.
Both, yes. The inpatient chart you saw is that we might not be using more hospital days, but every hospital day costs more every year. So you've got inflation pressure in pretty much every service category, and then you've got utilization or use of services pressure in some categories.
All right, inflation, one answer. One answer. Is that the only answer? Go ahead.
There's also, and Dave with PEEHIP, he certainly he's an expert in the drug field.
Who's the expert?
Dave here.
Dave, you're the expert?
And let me make a comment that he probably
Okay,
could also
okay.
jump on this as well. But in the medical for our plan has really not been the problem. It has been in the prescription drug area. And on the prescription drug area, you can isolate into a few areas, but one of the areas, to give you an example, is what we call GLP-1s. It's for diabetics. You'll see the Ozempics, Mounjaros.
Weight loss drugs.
Yeah, these are drugs that, 5-6 years ago, there was not hardly any expense out there. Today, we're spending close to $25 million for those drugs. They are very good drugs. The efficacy of these drugs are great, but they're just extremely expensive, okay? And so when you look at a population like ours, as you saw on those charts, and you see all the diabetics that we have, well, a large percentage of those folks are on one of those GLP-1s. And so what we're seeing on that end of it is our prescription drug costs are just skyrocketing within our population. The second thing that we're seeing as we're moving forward, and you'd mentioned the D, I think you're maybe referencing the Medicare drugs, Part D. And the federal government has made some changes in the amount of funding that they're providing to the plans. We are seeing our costs double in that area. So we're going to see, on an annual basis, about a $30 million increase just on the Medicare Advantage product. So that's one that...
Would you mind if I call Dave, the expert, up and have him tell me some more about that? I'm interested in that. Is that all right?
Dave, I don't mean to put you on the spot, but you are the expert here.
All right, so good afternoon. I'm Dave Wells with PEEHIP. I guess just a little bit of general information around Medicare Advantage. So generally, a Medicare Advantage...
Medicare Advantage is the prescription drug Part D, is that correct?
It's A, B, and D.
A, B, and D.
So it's hospital, it's medical, the doctors, and it's prescription drug, all wrapped into one product. So if you contract with a provider like UnitedHealthcare, Humana, whoever, to deliver that service to your members, you pay them a fixed monthly rate. You don't actually pay claims. You're paying like a subscription fee to that provider. The plan then, UnitedHealthcare, whoever it is, they pay the claims. They get money from the federal government in addition to the subscription rate that you, like PEEHIP or SEIB, pays them to make their economy make sense. A couple of things have happened recently to turn that.
So there's two payees, basically.
Federal government is a big source of the funding to that, and then the plan like PEEHIP paying for their rate. A couple of things that have happened that have turned that upside down. One, the federal government has said the amount of money that we're going to be giving you going forward is going to be a lot less than you thought it would be.
When did they say that?
That came out this year directly from Medicare.
Say that again. They say they're going to start paying us less?
So the growth rate that they're going to be paying going forward is less than it previously was behaving in previous years. So when the actuaries were looking at Medicare Advantage plans, they were seeing how the federal money was moving over year, how it was trending, and all of a sudden that trend was bent flat or downward. So
they bent it down.
The federal government.
Yeah.
Yes, sir. And it's a cost-saving measure by the federal government that's removing hundreds of billions of dollars out of the federal deficit.
Cost-saving measure on the federal government.
For the federal government, not
but we
for
still
plans
have
like
to pay
us.
it.
Correct. We have to pay more. So that funding piece that was coming from the federal government is not as rich as we anticipated it to be. The second piece of it is what we have to pay for prescription drugs. The Inflation Reduction Act changed the split of the bill that the federal government paid for prescription drugs.
Isn't that Medicare. The bill the president said should have been named the Green Energy Bill or something like that?
I'm not familiar with that.
Never mind, go ahead, I'm sorry.
So the Inflation Reduction Act, federal government previously was paying 80% of the cost of drugs once they accumulated to an expensive threshold that a lot of folks hit during the year. So if you're a plan like PEEHIP or SEIB, you're only paying 20% of the cost of that drug through your plan, all bundled through your rate to United Healthcare, Humana, whoever. And then you had that tremendous relief from federal government, picking up 80%. That's now been changed to 20%, all right? So then all that share of cost gets shifted over to the plan. So if you're administering a Medicare Advantage plan, you're now looking at less new money going forward than you were counting on in your rate. And then you have huge more drug expense as a result of the change of that 80 to 20. So it's more expense, less revenue.
We've had a change from the Fed bending down of what they were going to pay, but the amount continues to climb, and that amount has to be paid by us.
That's correct, yes, sir. And so to be fair, there's
That's
not
that's a shifting of responsibility and cost then.
That's correct, yes, sir, yeah.
Wasn't there something, I don't mean to interrupt, but I'm on a roll here. So what about the aspect that a matter of where there was a cap placed on what the beneficiary is to pay?
Sure, yes, sir, yeah, excellent question. Another component of that Inflation Reduction Act is that Medicare Part D beneficiaries have a $2,000 per year cap. There was previously not a cap on what they could pay for their drugs. Now there is. They're not going to pay more than $2,000.
But the money still has to be paid. Who pays that? The feds
plan
don't pay it, and the beneficiary doesn't.
The plan
pay it.
does. So it gets shifted to
The plan does. That'd be Ussens.
That would be PEEHIP and, yes, sir, Ussens, PEEHIP and SEIB. And so the 2,000 is also a little bit more problematic because it's not just the $2,000.
One more question, just to make sure that
Yes,
I
sir.
got this straight. So I'm told that the feds then have reduced the amount that they're going to be paying, putting the burden on the plan and the beneficiary, but then they put a price control on the beneficiary so that they're limited on what they will or can pay. Therefore, that excess cost is all being shifted straight to our plans.
Correct.
Is that correct?
Yes, sir.
That sounds like a lot of money.
It's a tremendous amount of money. As you heard William say to his plan,
Do you
it's
have
the same
do you have a
experience.
clue on how much money that is?
I'm going to go off memory, but it's somewhere around $150 million increase for PEEHIP over next year.
$150 million.
I'd have to get you that exact number after this
increase
meeting.
For PEEHIP, and take a third of that for state. So we're talking about 200 million?
Well, ours is 30
30.
million.
And our increase is 152 million.
Okay, so close to 200 million. Just,
Our total cost for 2024, 2025 is 209.3 million.
thank you for that.
Does that include the higher ed retirees in that cost, or is that separate from the higher ed retirees?
I'm sorry, the what?
The higher ed retirees, is that included in that cost, or is that separate from that cost?
So the way that works is if the universities pay for their own retirees.
Yeah, I understand. That's why I'm asking. Does that cost, that 152
That includes everybody,
Okay, so part of that's picked up by higher ed.
right?
Okay.
That's correct.
Senator,
And that's a change this year.
The Inflation Reduction Act kicks in 2025. That's when the new drug rules
January
come out.
1, 2025, it kicks in.
That sounds like October 1st.
It'll be January 1st.
Medicare operates off of a calendar year and not our fiscal.
I understand. I'm working off another cap.
I see what you're saying. Yeah.
and I will say that this impacts the private Medicare Advantage market as well. It's not just the employer group side. So you've got private Medicare insurers who over the last year have been signaling that they are either going to have to raise Medicare Advantage premium or cut benefits. So
Kirk, I apologize. We've already passed that budget coming up. Did we include all this stuff in there? Say that again?
No, not factoring all of that in. We did increase the SEIB amount, but they're talking 25, 26. The budget you passed was for 25.
Okay, all right. So that's what we'll be dealing with come February.
Yes.
Lots of good news today, isn't there?
I'm keeping a list.
I bet you are. Okay. I apologize. I just want to make sure two things. I want to make sure that I understand what we're talking about. I want to make sure the public understands what we're talking about. And I want to make sure that our employees, state and PEEHIP folks, understand what we're talking about. We're talking about a shifting of major amounts of monies that's going to be on our doorstep to pay now because of the regulation changes and the effects of the law that was passed some years ago that's taken effect, and that's going to be a major issue for us.
Yes, sir.
And if I might add, we had a very short runway on this to react because the final notice for this didn't come out until April 1. And then they have a substantive.
Of this past year?
Of this past
Of
year.
this year.
This year. So we then had to scramble to figure out how to address it for January 1, 2025.
Welcome to my world.
Exactly.
How is that going to affect our plans, other than just costing more money? I mean, is that going to affect our services?
Right. The PEEHIP board just met last week. We met last Wednesday. And basically, what the board came to as a decision was we will have to increase our legislative ask to $904 per member per month. That will be our ask. That is an increase of $104 per member per month. We've been level funded now for 9 years. So our
Oh, you mean each employee, PEEHIP employee, is going to be asked
No, our legislative ask, what we will ask the legislature for. We right now get $800 per member
Just
per
want to
month.
make sure that everybody understands.
Correct. Thank you for that. Or I'd get a lot of phone calls, I bet.
Exactly.
We're increasing our ask by $104 to the legislature to where it would be $904 per member per month.
And how much, what is that cumulative?
That's an increase of $130 million, and our total PEEHIP ask will be $1.128 billion.
Okay, and the increase from the CEIB was what, 30 million, I think you said?
Well, that's just the cost of the new Medicare Advantage program.
Oh, it's going to be more.
No. It's separate from our ask.
All right. I'm going to need more medications.
Yeah, because we did have we did 3 different lines of business that we just went through negotiations. And so on one of the lines of business, we did get some significant savings. That kind of helps offset some of our requests. But right now, the executive committee met last week. They've made a recommendation that'll go to the full board next week. And our request would be for a 5% increase over the 105. So it'd be 1,055. I'm trying to recall off the top of my head. I want to say it's $18 million, I think was the total. I'd have to double check that amount, but I think.
I'm sure that'll come to us from, here in a little while. We'll see all those clear figures soon.
And Mr. Chairman, if I may add on, the 904 that we're asking for does not solve our problem. We are then going to go into the retiree trust and pull out $118.9 million.
Is state in the same position with that?
With the increase of 5%, we will make it through fiscal year 26. At that point in time, though, any carry forwards, which basically is the monies that we have that are over the amount of required reserves, all of that will be expended. At that point in time, if nothing else changes, or if the claims were to come in higher, then at that point in time, we would have to look at tapping the retiree trust fund. But at this point, we are not budgeting for using the retiree trust fund.
Thank you, Mr.
Yes, sir.
Wells. Thank you.
Thank you, Mr. Chairman.
I don't know about y'all, but I've about taken all the good news I can stand today. There is one thing I'd like to propose to see what we can do. First off, Patrick, tell everybody who you're here for.
Patrick Dean, I'm the Assistant Director for the Commission on Evaluation.
evaluation. That means you're the experts on trying to find where we can squeeze dollars. Is that accurate?
That's what you said.
Okay. Could you work with PEEHIP and SEIB and look and see where, if there's any administrative or overlapping costs that we can do short of combining, but somewhere where we could have some shared or uniform expenses or something along that line that we might be able to see some savings in?
I think we're certainly capable of working with both bodies. Of course, I'm staff of our commission. You're on our commission as well as some other members. We have a meeting coming up where we can bring that to our commission to officially approve as work product for us. But
I think we can move that along, but I would like for you to start working on that as soon as you can, at least informally, so that we can try to figure out by our next meeting if that's any feasibility there. Okay, I don't want to spin our wheels on something that's not going to save any money or be productive, but I'd like to try to get a feel. I think from PEEHIP and SEIB, I think they're both saying that they've looked at that somewhat and it doesn't look to be substantive. I'd just like to have someone else take another look and verify that some.
yes, sir. And we've already, as a part of this task force, started working with representatives on what kind of information would be helpful to inform those decisions.
Okay. Now, we mentioned about the costs and the things that's happened that occurred on April 1st. Now, this is not an unusual matter. The feds do this every year, do they not?
They do. I will say this was a shorter runway than normal. We usually have a little bit more time to plan. We had to be much more reactive this go around.
Well, that and also the amounts.
Really, that's what you say, the amount.
The amounts are
is not-
startling.
yeah, this was an unusual decrease in funding. I mean, we were all preparing. We knew that something was going to happen. I think most of us in the industry, though, were looking at, 10, 15, 20%. We were not expecting to see costs double. And in PEEHIP's case, was it 4 times? Yeah, there's one up 4 times. That's just outrageous.
Correct. And I don't know, we've talked about inflation. I will talk about the other side of that, and that is, if I might, part of our problem is $35.2 trillion in debt. We are, the feds. Mm-hmm. And I'm concerned about next year and how that's going to come into play. The politics of it is going to be a problem. Whoever gets elected is going to be faced with somewhere north of 35 trillion, close to approaching $36 trillion. Anyone put the math to that, where that comes in? I looked it up a little bit. The distance from the Earth to Pluto is a huge amount distance. But if you took the 35 trillion and divided that into that distance, you would wind up with, I think it was 19,000 solar systems end to end. I don't know. You can do that. I even did it to find out how many aircraft carriers it would be. But anyway, my point is there's a huge sum that I think is going to have an effect. And I think what we saw in April is not going to be the last of it. Our work's cut out for us in some way. And I think we've got to make sure people are aware of the degree of difficulty and the way it's going to affect and afflict us. And I'm not sure we fully understand it yet. I may be wrong. I hope I'm wrong about that, but we've got to plan for the worst because the best usually ain't going to happen. I apologize for that downer. Anybody got any other comments or questions? Next meeting, I would like for us to set up a date have a meeting. I would also like for us to determine and come back with some other. Now I know y'all got your homework. You're in a busy time, and I don't want to be overburdensome, but I would like for y'all to work and find out if there's any kind of overlay or overlapping that we can find some type of savings from. I want to make sure that we're squeezing everything that we can to find out where the savings can come from. And the second is, what happens if next April we're given another picnic basket like this one is? What do we do? Now, one answer we're doing here temporarily is we're going into our reserves, aren't we?
Correct.
So, I would like for us to deal with the potential of having another issue like this in April, and what do we do then? How do we face that? Because whatever we do, we're going to have to face it together, so we may as well start trying to deal with that. Would that be, can y'all consider that?
Sure.
Is that too much of an ask under conditions you're in?
No, we'll be happy to work through it.
So when would be a good time for us to meet? If I might, we're in September. I'd like to do it before Thanksgiving, certainly. Second week of November, maybe? Do you think that'd give you enough time, Patrick, to take a look? I'll take that as a yes. Would that give y'all enough? Okay. Anybody have a date suggestion?
Could we do the Monday again, November 4th?
The following Monday be better? The 11th? Yeah, yeah, that's true, so we can't do that Monday. 4th? Everybody okay with November 4th?
That's good.
All right, let's call it November 4th. Let's call it at 1:30 again. And we'll take a look at that. If there's if we have trouble with that date, please let us know, and we'll be fluid and try to adjust. But right now, let's set for November 4th at 1:30, and we'll deal with those two issues. Ladies and gentlemen, I have to tell you, there's when you get to these things, it's a matter of you've got to either pay for the services or give up the services. And we're getting to a point of where we have to deal with this in a way that is honorable for our folks and yet is affordable for everybody. And that's the decisions, that's our tasking. Any other questions, comments? Dr. Mackey, you've been mostly quiet. Dorian, you have any comments? Anybody else? All right, with that then, I guess we'll stand adjourned until November 4th. Thank you.